From the JAMA Network, this is JAMA Internal Medicine Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Internal Medicine.
Hello and welcome to our listeners around the world. This is Dr. Eve Rittenberg, and you're listening to JAMA Internal Medicine Author Interviews. Thanks for joining us. Today, we are focusing on shoulder pain, and we'll talk about an updated evidence-based approach to managing this common primary care issue. You can find a link to the excellent review article on shoulder pain that we discuss in this episode's description. Our guests today are Dr. Romi Haas and Dr. Mike Incze. Dr. Haas is a research fellow with a background in physical therapy at Monash University in Australia. Welcome, Dr. Haas.
Thank you. Thank you for having me today.
And Dr. Incze is a primary care internist and associate professor of medicine at the University of Utah. And he's also the clinical review and education editor for JAMA Internal Medicine. Welcome, Dr. Incze.
Thank you so much for having me.
So I'm going to start by asking Dr. Haas to set the scene for us. So Romi, how common is shoulder pain?
It's actually more common than you might expect. There's been a large systematic review done from all around the world, and according to that, it affects a median of 16% of adults each year. So just putting that in perspective, that's around nearly 1 in 6 adults who experience an episode of shoulder pain each year. So I guess if you've ever had a niggling episode of shoulder pain, know that you're not alone.
Absolutely. And also see it a lot in patients who come in to medical practice and want to know what's causing their pain and what they can do about it. And as I think about figuring out what's causing shoulder pain and what to do about it, I'm really struck by something that you say in this review article that goes against what I've always learned, which is that we don't really need to figure out and name a specific structural cause for shoulder pain, like bursitis or tendinopathy or impingement, and instead you suggest just calling it subacromial pain. So can you tell us why?
I sure can. Traditionally, we've always gone by the pathoanatomic model, which is the logic that if we can pinpoint a specific structure as the cause of pain and fix it, then the pain will go away. Mm-hmm. But we've actually got evidence that that's not the case. So using what we've seen on imaging, so structural abnormalities on imaging are incredibly common, not just in people with pain, but also in people with no pain or problems with their shoulder at all. The other thing that we know is that on imaging, these structural abnormalities that we see, for example, even small tears, tendinitis, these become more common with age, similar or akin to grey hair or wrinkles. So because of this, it becomes virtually impossible to differentiate between the structural abnormality that we see on imaging that may be causing pain versus these structural abnormalities that just may be a normal sign of ageing. And that's why we're steering away from that traditional pathoanatomic model and moving towards just labelling the pain according to the site, which is why we're calling it subacromial pain, pain beneath the acromion or on the front side of the shoulder.
Mm-hmm. It is so different than I remember learning and teaching.
It sounds radical, but it's actually very similar to what we do in low back pain. And you may be familiar with the concept of non-specific low back pain, mm-hmm. which comes for the same reasons.
You talked about describing this pain by its location. It is important to distinguish it from some other kinds of shoulder pain. Can you talk about where you do think distinguishing the type of pain is important in a clinical encounter?
Sure. I think in primary care, first and foremost, it's really important to distinguish it from rare but serious causes of shoulder pain. These may be things like a bony tumour, infection, inflammatory diseases, and also thinking about referred pain coming from the neck, for example, or even from the heart or lungs. But the other thing is that there are probably 2 more common specific causes of shoulder pain that we can look at differentiating, thinking about adhesive capsulitis, frozen shoulder, or gliohumeral osteoarthritis.
Great. So I'm going to turn to Dr. Incze. And Mike, as a primary care internist yourself, could you talk us through an efficient or an evidence-based clinical assessment of shoulder pain? Building on what Romi was saying about what it's important to figure out and what it's not important.
Yeah. Well, I think a thorough history and physical really remains the cornerstone of figuring out shoulder pain and helping your patients both understand the prognosis, the etiology and the recommended course of treatment. I think the history is largely focused on the things that we're commonly taught to ask about, just thinking broadly about duration and onset and location of pain and any other types of symptoms that people may be having that may actually telegraph things like non-shoulder causes of pain that may be shoulder pain mimics, or B symptoms, for example, that might telegraph an infection or a malignancy. And that physical exam, I think, is still really a critical part of the assessment as well, and something that I think most patients that are coming in with shoulder pain are expecting us to do with them. What Romi's and her colleagues' review really teaches us is that the physical exam is not so much to identify the specific part of the rotator cuff or specific tendon that may be affected, but rather to identify signs of potentially emergent shoulder conditions like a septic joint, look for shoulder pain mimics, and identify causes of shoulder pain that may have specific management strategies like, for example, adhesive capsulitis. We're all taught these sort of special tests.
Yes, I was going to ask about that, the eponyms. We're all so excited that we know, these obscure eponyms for everything. But tell me a little bit about are those useful at all? Are those not useful? Do you use them?
One thing that I found sort of liberating and interesting about this review is its de-emphasis on the special shoulder physical exam maneuvers. I think for all of us that have gone through medical training where you're quizzed on all of the different eponymous maneuvers, but then get into clinical practice and realize that the results of those tests don't necessarily always translate into nuanced management decisions. And reading about the pretty thin evidence or really specific practice environments in which those tests were studied, I think it can create a little bit of a discordance. And I really like that this review appropriately broadens the physical exam assessment to focus on larger categories of shoulder pathology like subacromial or glenohumeral or non-shoulder causes of pain, which probably more closely actually match to actual diagnostic and management strategies.
That's really helpful. I'm going to turn back to Romi now because I know this is a particular interest of yours and you touched on it a moment ago, which is when should we order imaging for someone with shoulder pain and when should we not?
Okay, so I think you've just touched on one of the key messages of the review, and that is that for the reasons that I alluded to before, routine imaging is not indicated in primary care unless you really suspect that there's serious underlying pathology, which we've talked about before. So looking now, changing the question around, as you said, and looking at when imaging is indicated, it would be if there's a history of recent or significant trauma and you're worried about a fracture, dislocation, or an acute tendon tear. If there's signs of serious underlying pathology, so fever, unexplained weight loss, a history of cancer. If there's progressive severe muscle weakness, maybe you're thinking about a neurological condition or again, an acute muscle tear. And then the other reason is if symptoms are really persisting beyond the timeline in which you might expect that they would otherwise have improved, and you are thinking about referral or some type of surgery.
Great, thank you. One of the other things I liked about this review is that in management of shoulder pain, we talk a lot about some non-pharmacologic approaches. So I'm going to throw this out now to ask you to talk about what you would be likely to recommend to someone who came in to see you with, non-traumatic subacromial pain, no indications that this is a non-shoulder etiology. And so what would your go-to management strategy be?
One of the things I really love about this review is that it appropriately emphasizes educating patients about the favorable prognosis of most subacromial pain, teaching self-guided exercise, and really utilizing watchful waiting as appropriate first-line approaches. And I really like the stepped approach for pain management that for most people can start with things like topical, non-steroidal anti-inflammatories, And if those don't work, then maybe progress to oral nonsteroidals or even landmark-guided corticosteroid injections. And I think things that I in primary care oftentimes get asked about, like going to a chiropractor or platelet-rich plasma and hyaluronic acid and ultrasound-guided injections, and some of these more expensive and invasive procedures don't really have a lot of strong supporting evidence. In my experience in primary care, patients with shoulder pain really are worried, when they come in, because all of a sudden, just basic things like getting dressed and doing basic household chores have become really difficult, painful, or even impossible if the pain has a subacute onset or presentation. And, a way that I might counsel a patient in front of me if they have a typical subacromial pain without red flags after reading this review would be something like, I hear how your shoulder pain has affected your day-to-day life, and I want to work together to get this resolved as quickly as possible. The good news is that the type of shoulder pain that I think you have, which involves soft tissues like tendon and muscles around the shoulder, tends to fully improve over the course of a few weeks, even without special treatment. The most important things are to avoid activities that exacerbate the pain, but to keep up gentle movement and exercises at home as you're able to. For mild pain, we could start with a topical pain reliever used as needed. And if that doesn't work, or if the pain is more severe, we could try oral medications or even a steroid injection here in the office, which may provide a little additional short-term benefit. In general, other types of injections, stronger pain medicines like opioids, and procedures haven't really shown to help people any more than the simple approaches. And advanced imaging like MRI doesn't usually help to guide treatment. No matter which approach we take, I expect that you'll be feeling better in a matter of weeks. And if things don't improve, or if new symptoms develop, we'll revisit the plan and consider an alternate approach.
Okay, can I just say that hearing that makes me think about what a great doctor you must be, because I loved hearing that, validating and acknowledging that the patient is really suffering as you then go through the rationale for taking this measured approach as opposed to lots and lots of referrals and interventions and treatments. Really a nice way of framing that.
I also loved how succinctly you did it, because I hear from a lot of doctors that they struggle with the time taken to actually counsel patients and explain that. But you did that quicker than you could have written a prescription for anything. So, yeah, it was fantastic.
Especially writing the prescription involves like typing in 25 things into the computer health record. So, yeah, totally.
Exactly.
So we are coming to the end of our time, but I wonder if either of you has a takeaway or a clinical pearl, anything else that you wanted to add to what we said today.
I think really the crux of it is that most cases of shoulder pain that present to primary care can be managed in primary care without the need for imaging or specialist referral. And so that's actually something that's really reassuring, and that we can hold with us knowing that we can treat these problems effectively.
My main takeaway is that rather than focusing on a lot of special physical exam maneuvers, that the initial assessment of most shoulder pain in primary care is really focused on ruling out dangerous conditions and shoulder pain mimics, and a few specific pathologies like adhesive capsulitis. And once you've done this, the treatment approach is largely the same, and it's based on education, paced exercise, and a conservative stepped approach to pain control. And this simple approach not only helps me in primary care in my patient counseling, but I think ultimately helps patients to better understand their condition and their expected pathway to healing.
Thank you so much. It's really been a pleasure talking to both of you. I'm Dr. Eve Rittenberg. I've been speaking with Dr. Romi Haas and Dr. Michael Incze about management of shoulder pain in primary care. You can find a link to the article we discussed in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.